I will introduce all four nurses now, and then they will each present. We'll start with Annie Power. Is originally from New Brunswick, where she graduated from L'Université de Moncton with a Bachelor in Nursing in 2002. She then worked in the ICU for 6 years, following the clinical teaching and lead of the critical care program at L'Université de Moncton for 8 years, before moving to Sudbury. She is now working as a stroke nurse at Health Science North for the past 10 years, both on the acute unit and the stroke prevention clinic. Next, Holly Love, who works with me, has been registered nurse at the Timmins District Hospital since 2004. She worked a large portion of her career in the ER and ICU before transferring to the OR, D-surgery, and then endoscopy unit. In June 2024, she transitioned into her role as a designated stroke nurse. Darla Caul has worked as an RN at the Sault Ste. Marie Area Hospital since she graduated in 2013. She worked on the acute medical unit, acute stroke unit, until 2022, when she assumed her role in the stroke program. Darla has been instrumental in revamping the stroke program and stroke nurse role over the past year, as the program underwent some major changes in structure and human resources. And lastly, Michelle Grandmaison has worked as a registered nurse since 2001 on the rehab unit. In 2018, the rehab unit at the North Bay Regional Health Center was transformed into the integrated stroke unit. Prior to this date, they would only see stroke patients that required inpatient rehab. Since they transitioned in 2018, they now receive all stroke admissions, unless they require ICU. She has been the resource desk nurse for approximately 13 years. Welcome, ladies. We'll start with Annie. Go ahead.
All right. So thank you, Danielle, for the introduction. I'm going to talk about the role of the stroke nurse here at HSN. Our unit is 5 South, 5 floor on the 5th hour. So it kind of all starts when the patient's admitted. There's a consult for the stroke coordinator, which is us, the stroke nurses, that will go in with the stroke orders. And then it will print out in our office. Then first thing we do the patient lookup, we do the chart review. Where's the patient, the presentation of the symptoms, past medical history, and all that. And then, just give me a second here. Oh, sorry. I lost my screen. Okay. And then I lost my notes, so I can't see my notes.
On your other screen?
No, both of them. Okay, well, I'll just go ahead. And then once that's done, then the neurologist by then will have seen the patient. So we review their notes. So now we're aware of the plan, the suspected etiology, which testing has been ordered, which new medication has been ordered. And now that we have all that information, then we are good to go and meet the family and the patient, and we complete our teaching. So we'll bring all our handouts with us, the treatment plans, the pods that Rebecca has talked about. We'll know their risk factors. We'll talk about the follow-ups in the clinic. So SPC is short for stroke prevention clinic here. And then any upcoming testing that could be done as an outpatient also, if not done prior to discharge, medication and rehab. I think the key important thing too, and I find when we do go see the patient, is to really be clear and explain, especially the testing part, so they understand why we are doing the testing. And I find, as I'm working both on the floor and the clinic, compliance with getting those testing done as an outpatient increases if the patient can understand clearly why we're doing the Holter, what we're looking for, why we're doing the echo. Because we see it in the clinic, if that piece was missed upstairs, when they come down for their follow-ups a few months later, and they haven't completed their echo or they haven't done their Holter, and they'll say, well, I'm not sure why that was ordered. So I think that's a very important key pieces in the teaching also. So we complete all that, and we'll go see the patient and their family once. We can go twice, we can go 3 times, as needed. So we make sure all the information is very clear before we complete all the teaching. And then So this is all the handouts that we'll usually give, including the PADH, which I haven't put on the screen. On the top right, we have the pamphlet. There's another side to that pamphlet with all the instructions of where to register and all that. But we give that on the floor also so the patient knows about their follow-ups. There's the clinic number and all that information. And also on the floor, an important key piece that the stroke nurse is part of is this interdisciplinary team. So we have a meeting every morning at 8 o'clock in the nurse's station, and where we discuss every stroke patients on the floor. And at this meeting, we have occupational therapists, physiotherapists, stroke nurse, charge nurse, social work, dietitian, bed flow, and the whole team's there. So we talk about the treatment plan, the neurology plan, the tests and everything that's going to be coming up for the patient's progress, also coming from the OT and PT side. And then we kind of discuss and come to an agreement of like, what's the best rehab disposition for this patient. And so that way everybody's on the same page, everybody knows, and our delegated tasks also during these meetings. So that decreases the chance of any errors, any orders being missed when the patient's discharged. So it helps the flow from acute to rehab or acute to discharge and outpatient rehab a lot better. And again, like I said, decreases the risk of having any errors. And then we also discuss the discharge and the follow-ups to the clinic, make sure that's put in the computer, all the orders are all done. And then once a week also, we meet with the community stroke navigator. They'll come in, we'll review all of our patients. Even if a patient was discharged a few days before, we have their information and we'll relay all that to the community stroke navigator so they can contact the patient once the patient's discharged home. And then another key piece of the nurse upstairs, we initiate and we coordinate the follow-up to our stroke prevention clinic. So we actually start the chart from the clinic. We started upstairs prior to the patient being discharged. And this chart contains any testing that was done or being done, any consult, and any test that will need to be done prior to discharge. If we need to do repeat imaging in 3 months, that will all be on that chart. The orders will be attached to it too. And then once the patient's discharged, we make sure this chart is complete and we bring it down to the clinic and give it to our clerks so they can process and start booking the patient with a date for the follow-up. And the stroke nurse on the floor also has to ensure that any testing, again, not completed prior to the admission, is ordered properly as an outpatient, as close to the patient's home as possible. So if there's an echo to be done that was done prior to discharge, we make sure we order it in the closest center to the patient's home, so it makes it easier for them to complete. And then we also assist with training and certification of the NHSS for all new staff. You have a role also of like a guide for any staff using help with the NHSS when they assess their patients. MRPs also will come and see us. We make sure best practice are always looked at and honored. And yeah, that's about it. And then that's our team. Well, most of our team, we're missing Dr. Deshmukh and then one of our clerks, but that's most of the team here at HSN.
Very good. Thank you very much.
So this is the day in the life of the stroke nurse here at the Timmins Hospital. So you can advance to the next slide. So I just want to say thank you to Danielle, who did our introductions. As mentioned, my name is Holly, and I'm the designated stroke nurse here at our hospital in Timmins. We have a 4-bed integrated unit here on our floor, and our overflow patients will usually typically go down to our medical floor. My morning typically begins with coming in, assessing any of our recent admissions that come to us overnight. Referrals will either come from our inpatient unit, which is here on a 3rd floor, or patients that are down on our medical floor. I will review the charts from the night before, and then I will also review the progress of our current inpatients. We have a designated nurse assigned to our stroke patients, and my role is to support their care and to make sure that we are all following best practice guidelines. Another big role for me is making sure that patient and family education continues throughout their journey, starting here at the hospital with admissions and then continues into them going home. I'll often bring a piece of paper my first visit with the patients in the morning, and I bring them each one of our stroke pens and a pad of paper, and I ask the patient as well as their family to just jot down little questions. Often their nurse will come in and get assessments done, but the time to answer all those questions isn't there. So a big role for us is making sure you have any quick questions, write them down. I give them like pamphlets and information, but I also want to make sure that sometimes it's that random question that they think of in the middle of the night. So they leave their little pad of paper at the bedside and I check in with them. Next slide. Another role that I play here in our hospital is in our inpatient code stroke. So when a patient on any of the floors in the hospital develops sudden signs of an acute stroke, there are some rapid assessments that happen. Imaging and treatment options are discussed quickly. So this is a process that kind of works between all of our disciplinary teams. So the nurse will go into a patient room using the fast symptoms. They notice that one of their patients is having acute stroke symptoms. We did discuss this a little bit this morning about, for us, they go to their MRP, and then the MRP will direct them to use hypercare to contact our on-call stroke physician. From that, the stroke physician gives them two options. They can either direct the nurse to initiate a code stroke overhead, or they can ask for them to wait until this physician gets there. Once a code stroke is announced overhead, I will proceed to whatever floor it is called for, and I will stay with that patient and their nurse throughout the whole duration of that code stroke. So I'll start with them from their inpatient unit, go down to imaging with them, follow them over to ICU, and then see whether or not telestroke is initiated, stay with that patient, and act as a liaison between the nurse from the medical floor or surgical floor, wherever that patient came from, and stay with them until their admission to their new department. Or sometimes that means obviously going back to their initial unit. Next slide. So as I mentioned, my rig role here is to assist in the transition to them getting home. So I will complete community stroke program referrals, act as a liaison between the Timmins and District Hospital, and use our March of Dimes navigator to initiate some outpatient resources and programs for our patients. I will also initiate and make sure that the referral is done to come see us back at our secondary stroke prevention program. And then just really make sure that anything that they have need in terms of resources has already been started at the hospital, whether or not time they need outpatient Holter monitors, echoes, that sort of thing. And we'll start their outpatient stuff here before they're discharged.
I'm going to talk a little bit about what I do here at Sioux Area Hospital as a stroke nurse. So our Sioux Area Hospital Stroke Program, we are the District Stroke Center for the North Shore Health Network. So Blind River Hospital, Thessalon, Matthews Memorial Hospital, Lady Dunn Health Center, Hornpain Community Hospital. And we have an acute stroke unit. There are 4 beds on the acute medicine unit. We have an inpatient rehab unit, which is 27 beds. And we have a stroke prevention clinic, which runs 1 to 3 clinics per week. For staffing, we have a 0.6 to 1 FTE stroke nurse, which is responsible for both inpatient and outpatient, the stroke prevention clinic. And then we have a 0.6 FTE program assistant and a 1.0 FTE district stroke coordinator. Our 2025 statistics, we had 218 stroke or TIA admitted to the acute stroke unit, and we had 88 stroke or TIAs transferred to the inpatient rehab unit. And we also saw 300 new patients in the stroke prevention clinic. So for case coordination, what I usually do is take a look at the referrals that are sent to the stroke care coordinator. I just review the chart and I collect the metrics from the chart. And then there's interprofessional collaboration that occurs with physicians, the rehab navigator, case reviewers, frontline staff, and stroke unit leadership. We ensure that the stroke best practices are being adhered to by means of, relevant team members are being referred, and that stroke workup is being completed in a timely manner, and recommended timelines are being followed. So for each patient and family, I try to go to see them at least once while they're still in the acute phase. So I will provide them with the Your Stroke Journey book, as well as what we call a base package that includes pamphlets with information regarding just kind of general risk factors like hypertension and things they could do lifestyle-wise to help reduce the risk for stroke, such as like diet, physical activity, and then things they may encounter like post-stroke depression, as well as video resource links that they can check out online. And then from the chart, we will determine, if they have any specific risk factors and provide them with education pertaining to that, such as atrial fibrillation or carotid stenosis or smoking. For quality improvement, we've been attending Code Strokes, organizing and participating in mock code strokes, participating in the Stroke Quality Committee and other local and regional forums, managing databases of metrics for quality monitoring, and collaboration with the DSC and clinical educators. So recently, like the Code Stroke Policy Update, stroke order set reviews, and frontline staff education and orientation. And for what's next, in 24-25, the stroke program underwent some major structural and staffing changes. So at that time, the main focus was optimizing the stroke prevention clinic and reducing the lengthy wait list, which we did accomplish. So our plans for 2026 are to optimize the inpatient role of the stroke nurse. So we have refreshed our brochure, Welcome to the Stroke Program. We are working on providing education for the frontline nursing staff for greater involvement with patient education and educating families, and bringing the March to Dimes community navigator into the acute stroke unit and collaborating with the community navigator during the acute phase, as opposed to how it is right now, where they're involved in once they are at the rehab stage. We're also rolling out patient surveys inspired by HSN and institute follow-up phone call post-discharge. So something that's kind of in between the phase of leaving the hospital and coming to the stroke prevention clinic, just kind of doing, touching base with the patient and seeing how they're doing. Maybe they need an appointment sooner. They have some concerns or questions.
Good afternoon. Imagine a place where minutes decide a patient's future, a place where time is brain. My name is Michelle Grandmaison, and I am a stroke nurse at the North Bay Regional Health Center. Today, I'm taking you through a day in the life of a stroke nurse, a role that blends acute care, rehabilitation, and compassionate education. Stroke nurses do not just administer medications. They are the primary guardians of neurological function, managing patients from admission to recovery and rehabilitation. We are very fortunate to have an integrated stroke unit at the North Bay Regional Health Center. Our unit has 30 beds, 4 of which are designated for acute stroke patients. The remainder of our beds are for patients requiring rehab. They can be stroke patients or non-stroke patients. Next slide, please. And next slide, please. When someone presents at the North Bay Regional Health Center with a suspected stroke or TIA symptoms, they are assessed in the emergency department. The emergency team evaluates and then decides to admit to our unit, critical care, or transfer to another facility with higher level stroke care. Prior to transfer from ED to our unit, the ED nurse will call with report and handover. Next slide. When each nurse at shift change will receive a report from the previous nurse about each of their patient's condition, acuity, neurological status, vital signs, medications, and diagnostics. Nurses review the charts to see the diagnostic results, progress notes, ongoing tests, and assessments required. Based on the charts review, they will prioritize which patient to assess first. Nurses then head to the bedside. This is critical for establishing a baseline for neurological status. Morning assessments include neuroassessments, vital signs, blood glucose, etc. During the acute phase, these assessments are completed every 4 hours and as needed if change in condition is noticed. Typically, the first 48 hours of a new stroke admission is quite busy with diagnostics and assessments. The complete multidisciplinary team then assesses them. The team will follow up with a primary nurse of their assessments to provide safe care. If there is a deterioration in neurological status, the physician is notified immediately. Time is brain. If the physician deems necessary to call a code stroke on the deteriorating patient, we have a process in place. The MRP activating the code stroke will call our emergency department physician to give report. The primary nurse will follow and stay with their patient in ED during the code stroke. Urgent CTA will be completed to rule out hemorrhage or to identify large vessel occlusion. Depending on findings, IV thrombolysis may be given. For a hemorrhagic stroke or transformation, blood pressure management, neurosurgery consult, and potential reversal of anticoagulation will be initiated. Once assessed and stabilized, the patient and nurse will return to the unit. If they remain unstable, then they are transferred to critical care for closer monitoring and ongoing assessments. Next slide. My role as a unit leader is coordinating care, ensuring patient safety, and supporting staff while keeping the unit running smoothly. I assign staff based on the complexity and skill mix. I support all nurses with complex stroke cases. I ensure stroke protocol and best practices are followed. Next slide, please. I act as a liaison between nursing staff, physicians, allied health, and management. I coordinate admissions from ED, external facilities, and CCU transfers. I also facilitate daily bullet rounds and handle bed flow while prioritizing patients. I support and mentor staff. I am not alone. I work closely with OT and PT to initiate early mobilization and SLP for communication and swallowing issues. Stroke care is a 24/7 team support, and I coordinate that daily care to ensure patients are progressing towards maximum level of independence. Next slide, please. I am not alone. Oh, sorry. Initial interdisciplinary team collaboration includes physiotherapy, occupational therapy, and speech and language pathology. The remainder of our interdisciplinary team include rehab assistants, social work, home and community care, our CNE, recreational therapy, as well as our pharmacist. We have an education board present on the unit that explains the multidisciplinary team and their roles. The team, including the primary nurse, attend bullet rounds daily, Monday to Friday, to review and discuss each patient on the unit. We identify challenges or barriers to discharge. The team will set goals with patients and families that are realistic and achievable. The average length of stay is approximately 5 to 7 days for acute stroke admissions. More severe strokes or hemorrhagic strokes typically have a longer length of stay. After the acute phase, many stroke survivors go on to rehabilitation, which is a separate admission but remain on the same unit. Stroke education is provided to learn about strokes, how to recognize signs of stroke, prevention, and what to do if one happens. With this knowledge, it helps people to act quickly in an emergency. Stroke education emphasizes that many strokes are preventable by managing risk factors. We provide a stroke toolkit binder to all of our patients upon discharge. This binder covers topics such as understanding stroke, stroke care, prevention, living with physical, emotional changes, relationships, returning to work, everyday tasks, leisure, and financial planning. Our social worker has recently created a support group which meets bi-weekly. This is available to all admitted patients and discharged patients. Prior to discharge, a referral will be sent to a stroke prevention clinic. Once discharged home, they will be contacted for their initial assessment and appointment. Their primary goals are to provide rapid assessment and timely testing, evaluate and manage risk factors, develop a personalized prevention plan, including medication and lifestyle changes. Education is also provided to family about stroke warning signs and lifestyle strategies to lower risk. We have recently added an outpatient community stroke rehab clinic. All patients that require ongoing therapy are referred prior to discharge. Day of discharge, the patient is given their first appointment to the CSR clinic. Stroke is a common and disabling condition, but many patients benefit from the care delivered by our CSR program. Making a difference in a life-changing event is intense and demanding. That is why I'm a stroke nurse. Thank you.
Thanks, Michelle. That's great information and across your all your programs there. So that was very helpful. Thank you. So now we have 10 minutes for Q&A. If you would like to type a question into the chat, I'd be happy to read it out to people. The evaluation for this session is up on the screen and will be put in the chat as well. If you would like to take a minute to fill that out, it shouldn't take too long. I have a couple of questions to start. I want to kind of ask all four of you, does the stroke nurse work both on the acute unit and in the clinic? Do you have both of those roles at your 4 sites? So North Bay?
Yes, for the acute phase as well as the rehabilitation phase, we have the same nursing staff to provide both those care.
And then who works in the clinic? Different nurse?
We have dedicated outpatient therapists. So depending on their needs, they will work with a physiotherapist, occupational therapist, or a speech and language pathologist.
Right. And then you have a stroke prevention clinic?
We do. We refer all of our stroke patients to the stroke prevention clinic. And once they are discharged, they are notified of that discharge, and then they will contact that patient to set up their initial appointment and assessment for ongoing following monitoring.
Right. And is that a different nurse that works in that stroke prevention clinic?
So we're pretty
It's not you.
Pardon?
It's not you.
No, we do have dedicated stroke prevention clinic nurses.
Okay.
And they have a composite position where they work there as well as on the acute and rehab stroke floor.
Right. Okay, great. Thank you. What about the Sioux? Darla, do you do both?
Yeah, so I work the stroke prevention clinic, and then I also do inpatient education and whatnot.
Right. And do your patients, all your patients get referred to the stroke prevention clinic?
The majority do, yes.
Okay, good. Thank you. Timmins and Holly, do you work both on the acute floor and in the stroke prevention clinic?
I do. So it is myself on the floor and then as well in the stroke prevention clinic. Yes.
And are all your patients referred to the stroke prevention clinic?
The goal is to refer them all. We're actually tracking right now the patients that aren't being referred and finding out why they weren't.
Okay.
Yeah.
Excellent. Excellent. And Annie, I think it's a little different in Sudbury.
Hi, yes. So here we have, we do work both the stroke prevention clinic and the floor. We have 2 nurses, full-time always in the clinic. And then we have 1 nurse on the floor. And then we rotate. We used to rotate every so 3-4 months. We're actually going to try to rotate every month, just so that there's a good flow, and then it helps also that when you're working on the floor in the clinic, it's very two different jobs.
Right.
But once, if we do a quicker rotation, I just think that the workflow is going to be better.
Yes, for sure. And do your patients at Health Sciences North have their secondary prevention clinic appointment before they discharge, or do they get called after for that appointment?
They get called after. We've tried looking at giving them an appointment before. Our clinic is very, very busy, and we do have to often play around with their schedule if the
Right.
physician was supposed to be here and he's not here. So our clerks are often rearranging our schedule. So it would be too difficult to give them an appointment before, but we do give them a timeline of when they're going to be called with their appointment. And like in my presentation, we give them the pamphlet for our clinic with their number too, and we encourage them to call if they haven't had any news within a few weeks after being discharged. But yeah, that seems to be working well.
Okay.
Yeah.
Very good. Thank you, Annie.
No problem.
Darla, I just wanted to ask you about, you mentioned the rehab navigator, and many of you have spoke about the stroke community navigator, but could you tell us a little bit more about that rehab navigator that you guys have?
So it's a relatively new position. I want to say in the past 2 years, it was started, and what they do is help facilitate the flow of patients from the acute medical or acute stroke unit to the rehab floor. So they take a look at if there's any indications that are preventing them from going down to rehab, such as they're on telemetry, and that's not something that they would do down in rehab. So they would just kind of look into that and see, why are they still on it? Is that something we can remove in order to get them down to rehab quicker?
Okay, very good. Thank you. The other question I have was for Michelle. Can you just tell us a little bit about, if you know anything about it, the support group you mentioned with the social worker? Something that you guys are doing?
So Courtney, our full-time social worker, is quite passionate about supporting our patients throughout their journey from the acute phase to the rehab phase, up until they are discharged home. And she thought it would be a great idea to invite stroke patients that are either currently admitted on our unit, as well as patients that have been discharged, just to talk about their stroke journey, from the initial phases to where they are now. That way they have that support of one another, that they can empathize that, they've all been in that same place. They can talk about post-stroke depression, reintegration to society, reestablishing relationships, loss of independence and how they've regained that, with ongoing rehab. So she, I believe, has had 4 of those meetings with patients, and it's been very successful. And the feedback has been phenomenal from those people that have been present during those support group sessions.
Excellent. So if you're a patient on acute care, you can attend?
Absolutely.
Okay.
Our social worker has a sign-up sheet outside of our office. So when she sees patients during her initial assessment, she will talk about that and offer that service. So if they do wish to be present, they can sign up and attend.
Okay. And do you know if there's a outline for the group, or if it's more of a casual conversation with whoever shows up and whatever the top of mind might be?
I believe she has general topics of conversation for each group, but it is very general. She does wish or want patients to share their story. It's non-judgmental. And again, just to provide that support for everyone going through.
Right, great. Our outpatient neuro program here in Sudbury was wondering if it's done in person or is it done virtually?
It's done in person.
Because it's on the unit.
It is.
Yeah, it's done on the unit. So acute patients can go as well as rehab patients because you guys are on the same unit, right?
Correct. And even patients that have been discharged also have often come back for the support group meetings.
Really?
Yeah, yeah.
They're
Yeah.
part of the community stroke rehab program.
It is part of the community stroke rehab program. Okay, so, and who's your social worker? Because I think my O&R people might want to reach out.
Courtney Banish is our social worker.
Okay, all right, so we can make those connections for them as well. Thank you very much.
You're welcome.
The final question I wanted to ask is if everybody responds to a code stroke in your hospital. I know some people mentioned it and some didn't, so we'll start with North Bay. You guys would respond to a code stroke?
So on our particular unit, if we suspect a patient is having a neurological event, we will contact the physician to give them our assessments. And if we feel a code stroke is necessary, then the physician immediately contacts the emergency department physician to initiate that code stroke. And that nurse will follow that patient during that assessment. We do not page overhead, like Timmons was mentioning, if there is a possible code stroke within the organization. Each unit would follow the same process that we do, where the primary nurse notifies the physician, would attend the ED for their assessments, and depending on the outcome, that would decide where the patient goes
Yeah.
to next.
So it's typically the bedside nurse that accompanies them.
Yeah.
Right, thank you. Thank you. What about Darla in Sault Ste. Marie? Is it you that attends the code stroke?
So I don't attend code strokes coming into ED from community, but I will occasionally attend the inpatient code strokes just to help facilitate the procedure and policy. If it occurs while I'm here.
Right.
And not in clinic. So it's not necessarily a requirement, but if I'm available, I will absolutely go just to help guide them.
Great, thank you. And Holly and Timmons?
So yes, I do attend any code stroke that happens during the day while I'm there at the hospital.
Yeah, and it's an overhead page.
It doesn't, it's a page overhead that's how I get notification. And then I will stay with the patient until they are either admitted to ICU or back to whatever department they came from.
Right, okay, thank you. And Annie at Health Sciences North?
Yeah, so like most of my counterparts, it's the primary nurse, but if it happens on 5 South, we will accompany that nurse. We will contact our neurologist. We'll assess the patient. Well, I've brought down patients to the CT also with our doctors. So we'll do what we can, but we're not the primary one to attend, and we don't attend in the emerge either.
Right, so it's the ones that are in 5 South, which is your acute stroke unit.
Yeah, so if I'm there and there's a stroke, we'll 100% jump in and help and do whatever we can. But yeah, we're not the primary contact. Yeah.
Right. Okay, thank you.